Hi everybody, I'm John, I'm the head of BI in Somerset. Perfect link there from Chris towards the end. I'm going to talk to you today about how we're starting to use integrated data to inform decision making in Somerset. Kevin can't be here today, so the second part of the presentation I'm going to cover on developing an approach to capitation using integrated data. So, first of all, this sort of chart's probably, or variations of it are probably quite familiar. Somerset's got an ageing population, and quite dramatically so. We know, fundamentally we know that we can't change that, so we know that we need to get better at managing an elderly population. So back in 2013, 2 or 3 years ago now it was, we started building integrated data. We managed to pull it together very quickly, including social care, primary care, community services. We managed to do all the difficult bits very quickly, and we sent it off to York University for some help in understanding what we could learn from that data. So I'm not going to go through all the detail that Chris did in the learning. I'm going to just take the high-level messages that we got from it. This chart here represents the relationship between age and the percentage of the population that have long-term conditions. So as you might expect, the older people get, the more likely it is that they have multiple long-term conditions. When you combine that with this chart here, which demonstrates the relationship between costs and the number of long-term conditions, also in settings of care here. So if you've got 6 or more long-term conditions, you're on average very expensive. So when you've got an ageing population and there's a strong relationship between age and the number of long-term conditions you've got a financial problem. So we combine the two and we put them with a 5-year demographic forecast, and we found that with our current way of delivering healthcare, we've got a pretty unmanageable £140 million projected deficit, which we need to resolve. So that was all quite a long time ago now. As I say, we got there a couple of years ago, and since then we've come quite a long way. There's a joint Vanguard in Somerset. It's a South Somerset Vanguard, which is a PACS Vanguard, and the CCG have a very ambitious transformation programme. It used to be called Outcomes-Based Commissioning, it's now called Somerset Together. It's all about integrated care using 10-year capitated budgets, potentially, with accountable care organisations, focus on improving outcomes, and importantly the prevention and better management of long-term conditions. Okay. So before I get into this, the South Somerset Vanguard's been up and running for a while now as well, and they actually use our integrated data to enrol patients. So we give them a shortlist essentially of the multi-morbidity patients, and clinicians review that and pick patients to go onto their new care pathways. So the journey that we've been through with Somerset CCG in working out the strategy for better managing patients with long-term conditions, we've used integrated data all along the way. Firstly, we were focused on the high acuity patients, the 3+ cohort. And you can see here, this is very simple visualisation of service utilisation for that cohort. As you would expect, different specialties in different care settings have a different utilisation rate for that part of the population. We also use the integrated data to do some geographic analysis to look at potentially to try and work out where boundaries of social care organisations might sit. We've moved on a bit from here now, but as you can see, you can use integrated data and look at where people live, look at where services are provided, and try and work out where you might want to group services and populations together. So I think the important thing here is that before I get onto the capitation part of the presentation, we use the integrated data to define the problem, as many other people have. Age doesn't drive costs in healthcare nearly as much as multiple long-term conditions do. So we define the problem with our integrated data, And as we've been working out how to solve the problem, we've used integrated data all along the way to answer the difficult questions. I mean, if I'm honest, this is the tip of the iceberg. We're now integrating patient activation data into our Symphony data, and as you can imagine, we want to understand the relationship between increased patient activation and cost. We're also answering all sorts of questions. I won't labour that point. I'm going to get on to capitation. So, capitation. This is a presentation Kevin gave to a working group with Monitor, prepared by York University for us. And it's designed to outline some of the thinking on how we can use integrated data to develop capitated budgets. So, back to the famous Symphony chart, and I'll explain why in a minute. In the traditional academic way, they managed to take a relatively simple idea and make it look extremely complicated. These are examples of some very basic capitation formulas. I'm sure you're all aware of this, but I mean the basic principle of the capitation formula is you take the cost of the population, you take the number of people in the population, you divide one by the other, and you get a cost per population. We could just do that and hand that as a budget over to a accountable care organisation, but I don't really think that counts as intelligent commissioning, so we're going to use capitated budgets to incentivise behaviours for an accountable care organisation. So if I just explain this briefly, so the average cost per person is equal to a base cost for a cohort plus multipliers. So what we've got here in the top example is you could say, I want to have a capitated formula that varies based on age, and you've got a multiplier and a marginal effect of age. So the number of people in an age cohort you can't control, but you could build an incentive to say, I want you to be more efficient and reduce the costs, age here and beta, of treating that population, and then you add a bit on the end, which is essentially a risk adjustment to account for the fact that you'll probably get your projection wrong, particularly when you're using 10-year capitated budgets. So more relevant to the learning that we've had so far is the bottom formula here. So in this equation, we've got the average cohort cost plus the number of people with long-term conditions. And this is a bit more interesting. You can start to see how you could either incentivise fewer people with long-term conditions, therefore you're incentivising the prevention of long-term conditions, or you can incentivise the cost of treating people with long-term conditions. And then you've got the risk bit on the end as well. This is the tip of the iceberg. I mean, CCGs are funded by a demographic-based weighted capitation formula. You can consider anything you want, really. I mean, you can see there's an example down here. You could keep going forever. For example, smoking prevention. You could add in, if you knew the marginal effect of someone who smoked, you could build it into the formula. But the trick to get right is to link what you want, what you know you need to incentivise, to the financial incentive that you're building into the values in the formula. So I'm going to talk a little bit about the work that we're doing with York to understand, firstly, to calculate the base values of what that formula might be. So the current state, if we were to do a capitated formula based on say 14, 15 or 15, 16 costs, what would those marginal effects be? So it's a two-part linear regression model. So firstly, it explains whether or not someone receives any care. Secondly, if they receive care, it explains what the cost of the care is. We then present it as a, I think it's a generalised linear model as marginal effects. I think if I get onto this slide here, this visualises it much better. So what you're seeing here is the marginal effects of demographic factors on the population. So this is the adult population. There's 381,000 of them in Somerset. The average cost is £1,600. So you see here the marginal effect. Everything on the right here is higher than average. Everything on the left is lower than average. So actually, if you look at the elderly population, they only cost £805 more than the average adult population. If you die in the year, you cost a lot more, which we might expect. If yeah, the deprivation bit was an interesting bit. We added mosaic data, demographic indicators into the data to look at the marginal effect of deprivation. And actually, the deprivation fifth quartile is the most deprived. The marginal effect was relatively insignificant. So, I'm jumping about a bit, sorry. So this is the most relevant. So these are the marginal effects of different long-term conditions. So again, you've got the adult population and the average cost. And you can see here dementia. The average dementia patient costs about £2,000 more than the average adult member of the adult population, and there's about 5,000 of them in the population. So if you wanted to incentivise specific, the better management of specific long-term conditions, you can use this sort of analysis, and you can build it in as a variable. If we go back to the formula, you could build it in as a plus here, and you could say, I want you to, in 10 years' time, I want there to be fewer people with dementia in the population, and I want the average cost of treating those patients to be cheaper than it currently is. So I hope you can see now that how the analysis that we're doing with the integrated data is going to inform real decision making, and we're going to link it to the CCG strategy to incentivise the behaviour that we would like from accountable care organisations.